Right. Thank you all for joining us today, for coming back for the third session of the Agenda 111 seminar. Today we have with us Dr. Dagan Schwartz. He's a senior lecturer at Ben-Gurion University and the hospital director of medical management at Beilinson Medical Center. It's a great privilege to have you with us, Dagan. Thank you, and the floor is yours.
Thank you very much, and good morning to everybody. I will be talking a little bit about our experience in health system management, hospital building, and I will touch specifically about quality assurance, quality improvement, and how to make a system work, which is a lot of times much more difficult than actually building a single unit. I have experience in emergency medicine. I'm an emergency physician for the past 30 years or so. And I have a PhD in health system management. And I was also assistant medical director for our national EMS system, Magen David Adom. So I'll talk a little bit about all of these. I'm also director of emergency management. That means preparedness of our hospital for emergency scenarios, but I understand you already had a talk regarding disaster preparedness and all of that by Yechezkeli. So I will not touch on that topic unless you have specific questions. I've prepared a presentation, but I'll be happy to talk about whatever points you find more interesting, to elaborate on any topic that you think is of interest of you. So the presentation is just sort of a skeleton for the talk, but you can jump in, ask questions, and I'll do my best to respond. So the things I was hoping to talk about, but again, this is completely flexible, is first of all, Clalit HMO, which is the largest HMO in Israel. I'll talk a little bit about later. It has both hospitals and primary care facilities. And I'll talk a little bit more about my hospital, Beilinson Hospital, which is part of the Rabin Medical Center. I'll talk about quality assurance, which is a very important topic, and a lot of times we don't know how well we're doing, and I think measurement and transparency are crucial for any system, specifically health system, that wants to do good. A little bit about integration, a little bit about systems for emergency medicine and trauma care. I will not talk about disaster preparedness, as I said earlier, and then about how we take care of the human resource, which is the most important resource in many fields, but specifically in healthcare. I think that's the most important resource that we have, and we need to find ways to take good care of it, and obviously to make it better. Regarding acknowledgements, so a lot of what I'm going to be presenting here is based on presentations from Clalit HMO. Some of the presentation I took the liberty of using. We have in our Ministry of Health, we have the quality indicators project for hospitals, and I'll be using some of their slides. We talked a little bit about our national EMS, about Magen David Adom, and again, some of the information I bring to you is based from their knowledge base, and obviously from the university where I'm a senior lecturer from Ben-Gurion University. So first of all, the health system in Israel, and again, I know the health system in Israel quite well. I do not know a lot about the health system in Ghana, but in Israel, every citizen is has to be by law covered by one of our four state-mandated HMO, okay, health maintenance organization. Clalit is the largest of them, and has also 14 hospitals as part of their system. We have Maccabi, which is the second largest HMO, and I think you had talkers from Asuta, which is part of the Maccabi health system. Until a couple of years ago, they did not have any general hospitals, but now they have a hospital in Ashdod, which they opened a few years ago. And they also have a lot of surgical and task-specific hospitals. Clalit was opened first in 1911, many years ago, many years before the state of Israel was actually in place, and sort of evolved through the years. And we have a law of our parliament that was enacted in 1996, if I'm not mistaken, that actually put the rules on our national HMOs and our national health care, and actually also state what kind of healthcare every single citizen is entitled to. And we'll talk a little bit about that. As I said, Clalit is in charge, taking care of something like 52% of the Israeli population. It has many primary care clinics. It has pharmacies, has dental clinic, it has psychiatric hospitals. Basically, it covers all aspects of medicine. And it has 14 hospitals, in which one of them, Beilinson, is where I'm working at. So this is just a little bit of our national health insurance law. As I said earlier, we have 4 HMOs, Clalit, Maccabi, Leumit, and Meuchedet. And they all basically provide similar standards of care. In terms of how do we cover the huge expenses of the healthcare, which is something that needs to be taken care of, because it's not a one-time investment, but it's an investment that actually you have to pay every single year. And in most cases, the better level of medicine that you provide, the more costly it becomes. And as the population actually accumulates to better healthcare, the demand grows and the funding needs to grow appropriately. In Israel, our healthcare is relatively low cost in terms of our GDP, and it's paid, first of all, by direct health tax, which is 3 to 5% of everybody's salary, and obviously additional funding is by the government. Okay, we also have many Israelis also participating in out-of-pocket payments. Many have additional insurances that provide choice of providers, provide sometimes easier accessibility. But basically, anybody who needs an urgent treatment, hospitalization, it's covered by the general insurance of the government, and he does not need to pay out of pocket. It's optional. We have what's called the basket of services, which is again decided by the Ministry of Health, which decide what are the services that each HMO needs to provide. Obviously, an HMO can provide additional services with cost or without cost, but the basket of services is the services that it is obliged to provide to all citizens without additional cost. Every year we have a conference where we decide which additional services needs to be placed within the basket of services, new technologies, new medications, whatever it may be. And obviously that needs to also be funded by the government. The health system in Israel is relatively effective if you measure output versus cost. And as you can see on the left, we have the total expenditure out of the GDP. And we see that Israel is relatively low compared to most Western developed countries, only 7.4% of the GDP. The leader in the cost is the USA with 17.2%. So we're relatively low, but if we look at outcomes, health outcomes like life expectancy and infant mortality rate, we see that we're relatively high up in comparison with other countries that even spend much more money for their health care. So we're relatively efficient in providing our healthcare. A little bit about Clalit. As I said earlier, we have 14 hospitals spread through the state of Israel. I don't know if it looks big or small, but the state of Israel is very small. Across, it's about 1 hour drive, 1.5 hour drive, all the way from the north to the south of Israel. It's about a 4.5 hour drive. It's a very small country, and we have hospitals throughout. Obviously, you can see that we have more hospitals concentrated in the center of Israel, where most of the population lives. The south is more remote and less populated. I said a lot of what Clalit does is primary care, and as you can see, we have over 1,200 primary care clinics, pharmacies, child health centers, physiotherapy, dental clinics, mental health, specialist centers, imaging institutes, and women's health centers. A few words about Beilinson, and then we'll talk more about the system. So Beilinson Hospital has been around for quite a long time, again, before the State of Israel was erected. It was the first place in Israel where we had a blood bank. It was the first place where transplanted was performed in Israel, first dialysis institute. It's one of the leading hospitals in Israel, and a couple of things that we excel in is transplants, with more than half the transplant in the whole country being performed here at Beilinson. We have a large cardiothoracic center, a large brain, both neurology and neurosurgery center. We're one of 6 level 1 trauma centers in Israel, and the hospital itself has 900 acute beds. We have in campus, we have a pediatric hospital. That means Beilinson does not see kids. We have a dedicated pediatric hospital within our campus, which is called Schneider Medical Center, which is not part of Beilinson, but works obviously in collaboration with us. And we also have on campus a large psychiatric hospital, Gea Hospital. This is a picture of the centers, and Beilinson Hospital is over here. We have a nursing school here. Over here we have the psychiatric hospital, and this is the pediatric hospital, Schneider. So it's all very close by. A little bit about our trauma and emergency services. So we have a helipad and receive wounded and sick patients, both by civilian and military helicopters. Here you see a picture of one of our ED care centers, and we'll talk about that in a minute. We have a 50-bed, relatively high volume emergency department that sees over 100,000 patients a year. Again, emergency medicine is something which is very different in different countries. It started off not that long ago, something like 40, 50 years ago, which in terms of history of medicine is not that long. And initially was just intended for very sick patients who cannot be admitted straight to the hospital, but it developed with the years. And when we talk today about emergency medicine in Israel, more than 50% of all admitted patients to the hospitals are actually admitted through the emergency department. So the emergency department has grown both in volume, in space, and in tasks. And today we see many, many patients. An average of every citizen actually goes to the emergency department at least once a year in Israel, which is a large number. In most developing countries, I would guess to say that true is in Ghana as well. At this point, you'll have a lot less emergency department visits. But as the services you offer and the quality of care you offer improve, so will the demand for emergency medicine. And that's something which grows very, very quickly once the population understands that they have an option to get easily accessible diagnosis, care, and admission if needed. And big advantage of an emergency department within a hospital is that we have access basically to all the services in the hospital, whether that be imaging services, the specialist service, and obviously if somebody needs an operating room or admission to the hospital, those are all available through our emergency department. A little bit about what we have in the emergency department. As I said, we have 50 acute beds, but over 50% of our patients are actually cared for in something which looks more like a clinic setting. It's within the emergency department, but the patients are actually called into physician offices to be evaluated and then wait in designated areas until we have all the results and we make a decision regarding their disposition. Something which is relevant for our corona pandemic, we have 3 negative pressure units. Obviously, in face of the corona, we had to actually build an additional place for isolation, for isolating patients. And we actually, the picture that you saw earlier, one of our ED rooms, we actually split that large area into 2, with 1/2 of it being designated for corona patients. So we are seeing quite a few corona patients these last couple of weeks after a very nice success of the immunization program and really a drop in the number of positive cases in Israel, something like we had 6 per 24 hours, which is amazing. But then probably both the Delta variant and the fact that it's been about 6 months since most of the population completed their immunizations and there's a lower antibody count in their blood serum, we've seen a rise in the number of cases. And right now we're in the midst of the 3rd set of immunization. Initially, it was for patients over 60, but now it's expanded to include all medical staff over 30 and all citizens over 40. So, and we're hoping that with the aid of the 3rd vaccine, we will be able to get a handle on the outbreak. We have emergency medicine specialists with coverage 24 hours, attendings. We have a very active residency and fellowship program currently with 15 physicians in training. Okay, so that's a little bit about Beilinson and about our HMO and about the funding of our health system. If there are any questions or anything else you want me to talk about regarding the stuff that I've covered, I'll be happy to address them now.
Any questions for Dagan? Edwin, you want to take over?
Yes. Good morning to everyone. I can see people are joining us as we go on. Thank you very much for making the time. We would like to take questions, or if you have any contribution, if you want to share an experience or point of view with regards to what has been shared, we would like to hear it. Thank you.
Okay, if there are no questions at this stage, we'll be able to answer your questions later on. I'll continue with the presentation and we'll leave some time at the end for any additional questions or comments that you might have. But again, as I said before, at any point, feel free to jump in and ask a question. I'll stop and I'll answer the question. It's not a problem. Okay, health integration is critical. A lot of times we have isolated islands of good health care, but they're not integrated, they're not connected, and therefore their impact is minimal. And the real challenge is to build something which is integrated, works well, and actually addresses the population's need in the best way possible. It's easy to talk about. It's obviously much harder to actually build it and to provide the care necessary. But basically, when we're talking about integration, it means that all the different components of our health system need to work together and need to complement one each other. And again, if we look at the most basic services, which is the public primary health posts or primary clinics, and how they connect with the community hospital. So obviously it's a two-way dialogue and a two-way system that allows both referral and follow-up services. I mean, if you need to send somebody to a test that can only be done in a hospital, then obviously the referral will be from the primary health care provider to the hospital. But also when a patient gets discharged home, he will need a follow-up, he would need continuing care, and there has to be a dialogue between the hospital and the primary health services that take over the care once the patient is discharged from the hospital. The hospital can provide, as I said earlier, specialized services. They can be laboratory services. Sometimes the patient has to come to the hospital to get testing, but otherwise you can just send his blood samples to the hospital laboratory if that's where you have your regional laboratory, which will be the case in many scenarios. We talk about imaging, specialist support, you need consults, you need, those are all available usually at the hospital level. Today, because of the corona, but not just because of the corona, we're using more and more telemedicine, telehealth in general. And I think that's something which is going to grow more and more in the near future. And if I was revamping my healthcare system, I think it would be very wise to look strongly into integrating telemedicine, teleconsultation, and telehealth in general into our systems from the get-go, from the beginning, because those can be cost saving, time saving, and I think that's what the future holds for us in general and in medicine especially. So whatever you can do through teleconsultation, especially if you have a larger country and you have a lot of primary care remote areas, that can be a significant improvement in the care provided to the population. Additional things that are needed, and a lot of times you have the primary care provider. Is there a question?
No. I have a question.
Yeah,
yes.
Go ahead.
Given the unique scenario of this particular project, which is looking to build several district hospitals at the same time, and with your recommendation of incorporating telemedicine, telehealth systems, at what point should, for example, a consultant consider that? Is it after the infrastructure has been built? Is it before you bring in the management services? Is it before you do installation? At what point should a consultant be looking at bringing the telemedicine wing into a healthcare facility?
That's a very good question. That depends how busy the consultant is. That depends what are the facilities available for both the primary care and the hospital consultant. But I would say as soon as possible, because I think telemedicine has an important role even before you have the facility. I mean, you don't need a full hospital to do a consultation. So I would start as soon as possible. These things also take time. Takes time for the primary care providers to know that there is a service and to know how to use it. So my feeling, and again, it's not that I have much experience in this, starting a new system completely like you have now in your region where you're building many, many hospitals simultaneously. But I would start it as soon as possible. Obviously, start small and then scale up. And I think, again, when you do a very big project, it's important to try to get input as soon as possible. That means if there's a hospital which was built first You use it sort of as a trial, and you learn as you go. So I think it's very important to start offering services, obviously based on your capabilities, as soon as possible. Use it like a pilot program. And then you can learn and you can actually improve as you go from what you learn from the stuff that you've already started experiencing. So I would start it as soon as possible. And also you might get insight into how to better build or better employ your staff based on the needs. Because when we try and guess ahead of time what are going to be the needs and what are the resources, we can miss. And the sooner we have actual data on what's needed, on what our capacity, what our needs are from the actual world life experience, the better we can actually build our system. Did that answer your question? Okay.
Yes, it does. Thank you.
Education. I'm an educator, so I'm probably biased, but I'm a great believer in education, and not just initial education, but ongoing education. One of the things that makes healthcare provider most happy about their job, most content about their job, is ongoing learning. The fact that they know that they're learning all the time, they get feedback. It's not like they get left behind. That is true for hospital, and that's probably more true for primary providers, which a lot of times feel alone, left behind, and do not get the regular updates that people in hospitals are provided with more easily. And therefore, I think it's very important to forge, I would say, a company to forge an alliance between the primary care providers in the region and the hospitals, to invite them for seminars, for patient visits, to go out to the field and see their work, and to make them feel that they're part of the system, that people care about their professionalism and their well-being. So continuous medical education in one form or another is crucial, both for quality of your healthcare professionals and for their well-being as well. And I would even say well-being of medical professionals, since the most important resource in the health system is the medical providers, they need to be invested in. And if you want both good people to come and learn how to be doctors, how to be nurses, how to be physiotherapists, whatever it may be, and you want them also to stay and not start looking once they've finished their medical school programs to work in more affluent areas of the world, which is a problem in many, many developing countries that invest much in medical education, only to find out that many of their graduates leave the country once their medical education has been completed. And then the country has invested a lot of money, but does not see any output in its investment. So you have to give the healthcare professionals a bright future to look at within their own country. And a lot of that has to do with money, but money is not the most important thing. I would say salaries is not the most important thing. It is important, but it's not the most important. But if they feel that they're in a quality system which appreciates their hard work, and in a system which is developing and providing good health care for the population, I think that would more likely keep more of your graduates within the country and within your health system. Integration needs to also be between the different community hospitals. Again, this can be for educational, this can be for maybe you have a specialist in one area in one hospital and you do not have that specialist in another area, and you can share these resources. Sharing resources may also be between laboratories, imaging services. It could also be manpower. I mean, you might have a gastroenterologist, which 2 weeks a month is in one hospital and the other 2 weeks of the month is in another hospital. I think that sharing, learning together, and dealing with the difficulties together is extremely helpful. And again, you need to have close collaborations between the nearby community hospital within a region. This is also important for emergency planning and training. If you have a disaster, and it seems like we're seeing more and more disasters as time goes by, both because of global warming, global change, and because of infectious diseases. And this is something which is we're going to have to be dealing with probably for the next many years. So planning and training and working together between primary care physicians, regional community hospitals, and the larger regional hospitals is all very important for us to be able to deal better with these types of emergencies, which are sure to happen. EMS, I'm not exactly sure how EMS, Emergency Medical Services, works in Ghana, but here in Israel has a very important role. We have a national EMS, which brings to the hospitals almost all patients which are not ambulatory, takes care of heart attacks, of traumas in the field, bring them to the hospital, and also is in charge of transporting patients from one hospital to another. Let's say we have a patient in the community hospital, but he needs neurosurgical services, which are all only available in the tertiary care center. So it would be our EMS system, which would be in charge in transporting these patients from various hospitals. They're also important in major emergencies like the most multi-casualty events, which we've had quite a few in Israel, unfortunately. We have a very large volunteer section within Magen David Adom, which is of great power. And during the pandemic, just to give an example, we've used Magen David personnel, EMS personnel, to do testing in nursing homes for coronaviruses, to provide immunizations within nursing homes and for the general public. So if you have a large and strong EMS, and if they have also a large volunteer, and that's something that is important to build, I think it has huge benefits for the whole country if you do have a strong EMS with a large volunteer section. And they can be very, very helpful in everyday emergencies as well as in large-scale emergencies like the COVID-19 pandemic. The last integration that we need to talk about is between the community and the referral centers. And again, similar to what we had between primary care outposts in community hospital, we have the same kind of interaction between community hospitals and referral hospitals. And again, they can provide ancillary services. Maybe the MRI is only available in the referral center. So if somebody needs MRI, he needs to be sent there. Specialist support, we gave the example of neurosurgery, which is usually not found in community hospitals. Heart surgery, transplant, all of those are usually a lot of times also oncology, special oncology treatment centers, only available in the tertiary care center. And again, these need to be connected with the community centers. Some of the stuff can be done again with telemedicine, especially if it's a large country and sending patients on a journey to another part of the country is very costly, both in direct expenses, but also they're far from the family. They miss working days. Usually somebody from the family member has to accompany them. And therefore, the strive needs to be to provide as much as possible of the care, even the specialist care, within the community. And again, if the patient needs a follow-up with an oncology, that can be done through telemedicine, or that can be done if he comes to the community hospital, where once a week there's a visiting oncologist who can see him. So especially if we have resource-limited population, we should do whatever we can. That should be already in the planning stages to bring the treatment to the patient and not the patient to the treatment. Sometimes you don't have an option. If the patient needs brain surgery, obviously it's difficult to do with telemedicine. I'm joking. But for most things, we need to really try and think about patient comfort and bring the medicine, the best available medicine to him. In Israel, we've, over the past couple of years, we moved more and more towards home care. Hospitals are very expensive. Hospitalization is hard for the families. Hospitalization has risks of iatrogenic injury. And basically, anybody who doesn't absolutely need to be hospitalized could probably be better cared for at home with the appropriate support. The support can be a telephone consultant. The support can be a pulse oximeter, which with Bluetooth connection, which sends us the data to the treating physician in the clinic or in the hospital. It can be many, many things. Today, we're sending patients home with coronavirus who need oxygen. So they receive oxygen, they receive a pulse oximeter. Every day, there's a call from the local clinic, from the physician to ask how they're doing, to follow up on them and see if they have an additional needs. And obviously also, if the condition deteriorates, to bring them to the hospital. So I think, again, when you build a system, and just as an example, in Beilinson, one of the most newly implanted departments in our hospital is a home care department, which sounds funny when you think about a hospital. I mean, how does hospital connect to home care? But again, we see that since we do have the specialist resources, then we can actually support many of our patients at their home through, again, telemedicine, a mobile lab that comes and takes their blood. And we can save a lot of hospitalization, which are both costly and very inconvenient for the patient. So that's something that I think when you're building a system today, you need to think about outreach of the hospital to the population, and minimizing admissions. I mean, sometimes obviously you don't have a choice, but a patient who can either be treated at home or at the hospital is usually happier and better cared for at home than in the hospital. If a patient needs monitoring, needs intensive monitoring, or needs something else, obviously his place is in the hospital. But I think many, many patients can be treated much better at home. Professional educational projects, again, this is crucial. We need research, we need education, and that actually what makes the system better and what makes our healthcare workers happier, which is something that we need to pay attention to. When you build something large scale, and one of the danger is building white elephants. Do you know what white elephants are?
I thought it was a Hebrew.
Yeah. Oh, it's actually from India. It's actually an Indian from India. White elephants are white elephants are very expensive because you have to feed them, but you cannot use them for work, so they're not utile. And we refer to white elephants as we had a few examples in Israel that somebody built a huge hospital or a huge section, and then when time actually came to use it, we found it was unnecessary or built incorrectly, and we couldn't use it. So again, this is always a danger when you build something on a large scale, that some of what you built you'll end up not using. And there are many programs. Somebody bought a very expensive MRI machine, but then he didn't have the techs to operate the MRI machine, okay? Or the electricity wasn't stable enough to support the MRI machine, or 1,000,001 different variations. So we need to be very careful and think thoroughly, and sometimes the best thing to do is do pilot programs. I mean, start small. For example, with an MRI and a CT, we have in Israel mobile MRIs and mobile CAT scanners. So we have sort of a truck, bring in an MRI. That's a lot cheaper, and you can use one MRI for multiple regions. Again, if you see that the demand for MRI, you need the MRI every day, then, and you've already operated the mobile unit for a couple months, and you say, wow, we really need a full-time MRI here. So it's justified to build an MRI within the facility. But then it's not going to be a white elephant because you've already proven the need for this facility, for this resource or facility. Again, this is a sad truth, but the strength of a system is not based on its strongest link, but on its weakest link. That's where things fail. And we have to always look for the weak link and see how we can strengthen it for the whole system to work better. The weak link in a system can be referral services, can be payment, can be a million and one problems, but we need to all think that thoroughly, and we need to monitor it once we've started to see where we are having problems. Usually a system that we've set up is not optimal initially and needs to be improved and modified with time. So we need to get good data, real data, objective data in relevant times so we can make decisions and modifications. And it's not realistic to assume that we'll get things right from the beginning regarding our needs and the best way to address them. It's something that we need to be flexible and move along with time and modify appropriately. A little bit about trauma systems. I'm an emergency physician, so I have a great interest in trauma. From what I looked in data from Ghana, trauma is not the leading cause, but infectious disease is the leading cause of mortality and morbidity. But as you build and as you develop, trauma is going to become inadvertently a bigger and bigger problem, and that trauma a lot of time tends to injure the young and healthy, which have many years to live and many years to contribute to the country. So even if the numbers are not as big as heart attacks or as strokes or other cancer or other problems, it has a very significant effect on society. And to deal with trauma, you need a good trauma system. And as I said before, it's not enough to have one good trauma center if you don't have an EMS system that brings in the patients and take good care of them on the road and saves the ones that can be saved. And it's not worthwhile to have a good trauma center if after you've treated acute trauma, you don't have places that you can send them for rehabilitation. So it's really a system. And I think the system approach is true for almost any field of medicine, but I will take this opportunity to talk a little bit about trauma systems. And again, in countries where trauma systems were set up according to the ATLS, the American ATLS, or other conventions, they were able to show a significant decrease in the number of patients dying, in morbidity, in mortality, and in morbidity. And it works. And for it to work, you need to build a system. And again, I was talking about a pilot system. If I was trying to design something, I would start within a region. I would start with one tertiary care hospital, which is a designated trauma centers. And I would start with the feeding community hospitals from that region and with an EMS for that region. And I would try and build something that works. Once I've proven and I've seen what works and how to best do it, and I know already what I need and how it needs to be done, then I would expand it to other areas of the country. And again, there's many epidemiological works that show that a good trauma system actually saves many, many lives, mostly of young people. And I would just let me just talk about the registry. And again, this is something that I think attention needs to be paid to already in the initiation stage, and that's transparency and good data. You need to have good data. Obviously, everything has to be digital. All the emergency medical records, all of those need to be digital. And you need to have good data to know what you're dealing, to know how well you're doing, to know where you need to improve, to know which places are doing well, which places aren't doing as well as can be, and to learn from one another. And part of this, when we talk about trauma, is a trauma registry, where all patients who get admitted to the hospital for trauma are actually listed, and you can follow up and see how well you're doing and what your problems are. Okay, imaging I talked a little bit about, and I'm gonna stop. Again, use of teleradiology is good. One additional thing I'm going to say about imaging is point of care ultrasound. Ultrasound are becoming very cheap. They're very mobile. Training for an ultrasound technologist or for a physician or for a nurse who uses an ultrasound is relatively simple, at least for some basic diagnoses. And we here in despite the fact that we have MRI and we have CAT scanners and we have everything here at the hospital, in the emergency department and in the primary care clinic, we use a lot of ultrasound because it's cheap, it's easy, it's sort of bedside. I mean, I have one personal ultrasound on me, and takes me 5 minutes, and I do a focused ultrasound exam. And I think when we're talking about countries with large areas and many remote locations, point of care ultrasound is a great diagnostic tool, which is cost effective and care effective. Intensive care units are very expensive. Obviously, if you're talking about neurosurgery and about cardiothoracic surgery and about oncology patients, you're going to need to have ICU units. And basically, they're extremely important for the function of a tertiary care hospital. We used them a lot also in the pandemic. And just a lesson that I think the whole world had from the pandemic, we were talking about not having enough ventilators. We were talking about not having many things, but when push comes to shove, what we really lacked the most were the providers. That is, ICU physicians and ICU nurses were missing, and they were actually the bottleneck, and not the machines, but the people. So again, if you're talking about preparedness for emergencies, about corona, then ICU care, despite the fact that it's very expensive, is crucial. Talked a little bit about rehabilitation. Again, you need rehabilitation to start in the hospital. You need rehabilitation centers in the major cities, but you need also rehabilitation services in the community and even at the patient's home. And again, you can do a great work in the acute care of the patient, but if you don't have rehabilitation to follow up, then you miss many of the potential profits that you have of your health system. Okay, we're towards the end. I think I have 2 more slides and we'll be done. And then if you have additional questions, I'll be happy to answer them. Sustainability. A lot of times we have a lot of money for the initial stage, but we don't plan well enough for the follow-up stage, and we don't have enough funding for the follow-up stage. Again, if you build a beautiful hospital and after 2 years you don't have the funds to keep it working, then you haven't done much, and that's something that you need to think of already ahead of time. You have to think that, again, once you improve your healthcare, the demand for the services grows, and obviously the cost will go as well. I think that providing good healthcare to your nation is crucial. It's one of the most basic things we can do for our people, but we need to take into account that it's not cheap, and the more we improve, the more the demand for these services grows, and people expect to get good healthcare, which is natural, normal, and good. but the costs need to be projected upward for the futures. We need transparency. We need to measure. As I said, we have a whole division within the Ministry of Health that measures hospitals to see how well they're doing, how many surgical procedures have complications, how quickly we identify problems. If we have people who die unnecessarily, increased morbidity, increased mortality, increased infections, all of those are things that we need to keep a close watch of if we want our money to provide us with the best outcome. We need to measure all the time. We need full transparency, and we need a quality assurance system. I'll finish here since our time is more or less over, and I want to leave a few minutes for questions, comments. So please.
Thank you very much, Dr. Schwartz. We would like to take questions directed at Dr. Please, if you have any question, we would appreciate if we could have it. We want to make the session as interactive as possible, so your questions or your comments are quite important to us too. Thank you.
If I can ask a question, Dr. Schwartz,
Ralph.
my name is Ralph.
Thank you very much, Ralph.
I'm interested in some of the points you raised as you talked relating to future expansion of services and buildings. You had mentioned an earlier one that as a hospital develops, you found a particular service that tends to lead in the expansion requirements. I don't know if you could, I know this might be peculiar to different countries and regions, but if you could list again what departments tend to be the most significant growth areas after a hospital is built.
Okay, that's an excellent question. But I would say, first of all, that you need to keep as much flexibility as possible. If I was building a hospital today and I could leave already empty areas that can be finished and designated afterward, I think that's a great idea because it's a lot less costly than after you've finished building, starting to build a new wing. So I would say, think about it, think about areas when you build, think about multifunctionality. I mean, if you see that one area of the hospital is of less use than you expected, and you have more demand for other services, you want to keep it as flexible as possible. But to be more specific to your answer, I think emergency medicine is one of the things that we see grow the most significantly. And again, that also depends how well your primary care system is working. Because one of the drivers of emergency medicine is if the primary care services are unable to meet all needs. For example, in Israel, and again, I'm sure this is different, but I'm sure you can find parallels within your system. In Israel, if I now have a pain in my knee and I want to see an orthopedist, and I call my primary care physician, I say, I need to see an orthopedist, and say, oh, no problem, in 3 weeks you can get an appointment. I tell them, well, that's all very good and nice, but I'm in pain right now, and 3 weeks is not really very helpful. I need an answer right now. So you know what, you can go to the emergency department. Why you can go to the emergency department? Because the emergency department is open 24/7. The emergency department has an orthopedist. You'll probably have to wait 4 or 5 hours to see him, but it won't be 3 weeks, and you'll get your x-rays, and you'll get your specialist evaluation. So that's just an example of how drives. Again, I have a headache and I need a CAT scanner, and I call a CAT scan of my brain, and I call to set up an appointment. They said, oh, no problem. We have an opening in 1 month from today to scan your head. And I say, you know what, I have a severe headache. 1 month is not a good enough answer. I'll go to the emergency department. So emergency department tends to fill in all the gaps within the primary healthcare system. Additionally, again, most acute problems need to be admitted, whether it's surgery or other medical problems, find their way to the hospital through the gates of the emergency department. At least in Israel, they said about 60% of all our admissions are not ambulatory. I mean, they're not scheduled. They're all people who came to the emergency department and were found to have an acute problem which needed hospitalization and were therefore hospitalized, whether it's in internal medicine, in orthopedics, in surgery, or other departments. So I say emergency department is definitely something that I expect will grow very, very significantly once the population understands that they have such a valuable resource at their disposal. Imaging is again something which, once again, the primary care physicians and everybody understand that they have the possibility of getting imaging and better caring for the patients through that. That's also something which is likely to grow very significantly in the first few years. Those are the two things I can think of initially. I'm sure you'll find out more as you go along.
Okay, thank you.
Ralph, if you can stay on, I had a question that I wanted to direct to the Ghanaian team, but since you're here, I think you can help me with it. I have also picked up a lot from what Doc said, but I wonder how feasible it is, given the original TOR that we have for this project. Not asking to divulge much, but how feasible is it in terms of the multi-functionality of the infrastructure we are building, the fact that we should incorporate home care and telemedicine even before we finish the infrastructure, inculcating mobile health services as side by side to the construction. And then now that he mentioned focusing on the emergency wing as the place that could be the focal point to growing the hospital. What is your take on it? How feasible is this?
Well, you can imagine that with a project of this scale,
yes,
the budget is stretched beyond imagination.
I believe so.
And so there is really no space on any of the projects for creating space that can be used in future.
Okay.
What I think strategically can be shared with the Ministry of Health and Ghana Health Service in particular is things like the idea of the mobile imaging services. If the hospitals in one geographical area can be grouped so that there is mobile imaging services available, it would actually present a savings on the project at this present time, and with good rationale.
I agree.
Because you'd immediately find that some of the hospitals may be even a little oversized for the population that they are planted to serve. And so it would mean expensive equipment would be completely underutilized cost-wise. And
I think it's not only equipment. I don't think it's only equipment. You know, a lot of times we put money values on the equipment, but personnel can be much more expensive.
That's a good point as well.
I mean, the tech, the radiologists, they're all better used if you do a mobile, which actually services a few hospitals.
Mr. D'Anthony, you can also. I see you are
definitely. Yeah, thank you so much. Edwin, actually, from what doctor was saying, he made mention of. Please, can you hear me?
Yeah, we can hear you very well.
Yeah, he made mention of piloting some of these mobile health facilities, because if you look at Ministry of Health, this is not the first time, when it comes to mobile facilities. But one thing is, like he was saying, these are things that can be undertaken in a piloted manner, because there are a lot of things that comes into being. If you want to start something like maybe a mobile city, there are a lot of things that comes into mobile city, getting the personnel, people to read the images, take the images, and then make it useful to the doctor, to the patient. And so we can, this thing can be started in a piloted phase. For example, we can start with probably somewhere close to Accra, and then with time we'll be moving from Accra to something like Tamale, Bolga, and the rest, knowing very well where resources are a bit scarce, or where, when it comes to some of these services like imaging and the rest. Apart from imaging, there are other things that when it comes to getting it in a mobile form, we can still do it in a piloted manner. We spoke about radiological diagnostics. We also go to laboratories, because there are a lot of laboratories that tests that sometimes a patient or a particular facility will require, but not all of them can run all these tests at the same time. It is the same thing. It's not every facility that can have CT, cath lab, all the modalities of imaging. And so, depending on the need of a particular region, these things can be piloted. And as they get grounded over there, like he said, in a mobile form, and we see that maybe every day now, instead of maybe 5 CT per week, now we are doing 15 CT per week. It means that there was a need to make provisions for, getting it permanent over there, because you cannot just say, you are building a hospital and therefore let's start putting CT, cath lab, all these things there. You might not necessarily use it. You spend a lot of money, but not making good use of it, getting the right, getting value for money. And so I think the pilot, it will be good we look at it, some of this, what he was saying, in a piloted manner. And if there is a need for future expansions, we need to find ways and means to, talk about it now, so that when the need be, when it gets there, at least, since provisions can be made for that, accordingly. That is what I want to say.
It's amazing that you mentioned that, because within my time working on digital health, I have come into contact with several companies, obviously Israeli, who can actually do imaging services for $1. You can imagine a company can read your MRI scan with almost 98% success for under $1. And such facilities can be taken advantage of, which makes the mobile services even much better.
Definitely, because it is capital intensive. Apart from the equipment, the personnel, in fact, even the mobility, a lot of things. And so, and some of these equipment are 3-phase equipment. Apart from setting them up, the power consumption, you may even go to some localities, the grid there, getting a 3-phase power supply there becomes a challenge. And therefore, it's good we are looking at these things at this time, so that it will help us plan and be able to approach this in a very effective manner. Thank you.
Ralph, you wanted to say something?
Yes, I wanted to add a slightly different dimension that I'd like Dr. Schwartz to perhaps give us some thoughts on. I'll start by giving an example. When the landline telephones existed, there was a very limited spread across the country. And it looked almost impossible to get a high phone coverage for the nation. The mobile phone technology completely transformed that. And the advantages therefore became widespread. I wonder what advice or thoughts would come to your mind, Dr. Schwartz, about how to leapfrog the limitations we have now with our current technological base, to land us into advantage in the growing field of technology and medicine.
Well, I would say a few things. First of all, technology and especially communication technology has made a huge change worldwide. And I think even more so in developing countries, since it's a lot cheaper to spread a cellular network than it is to landmines. And I think that practically speaking, if I was working to improve, then definitely you need your healthcare facilities primarily to be connected to a reasonable size network broadband, whether it be 3G, 4G, 5G, or whatever we're working with, whatever is available. But if you want good telemedicine, you need a reasonable network. And networks today are a lot cheaper. Cellular networks are much easier to spread and much cheaper to spread than landmines. But again, with healthcare, you need good communication. If somebody wants to call an ambulance, if somebody wants a consultation, then definitely the framework of a good cellular working network, reliable, is a must, is something that you need to have in place for all your health services to be available. Because if you don't have communications, it's very hard to provide good health care. So I think that needs to be hand in hand with the development of the health, of the hospitals and the primary care clinics that you're developing. You need to make sure that there is good cellular coverage in these areas.
Okay, thank you.
Thank you so much, Dr. Dagan Schwartz. Thank you for joining us today. The lecture was fascinating and very intriguing for me, and I'm sure that for all the Ghanaian team. Thank you so much. And
good luck.
Thank you. And I would like to invite our next speaker, Dr. Dina Zimmerman. Dina, I'm very sorry for being late so much. Dr. Dina Zimmerman is the director of Israel's Ministry of Health Maternal, Child and Adolescent Unit. She will proceed forward. Thank you so much. The floor is yours.
Okay, I'm going to share my screen and go back to the beginning. Let's check. Okay, is everyone able to see the?
Yes.
Slide? Okay, so after listening to the lecture about tertiary care hospitals and emergency care, we're now going to the opposite end of the spectrum, and that is the world of preventative healthcare. I've actually worked in both, so it was interesting to hear that lecture as well. What I'm going to focus on in the time that I have allowed is Israel's maternal child health clinics, and talk about them, first of all, past, present, and future. Okay, we're talking about prevention, and obviously there are different levels of prevention, with the best being, primary, never having the thing happen in the first place. If we didn't succeed, then secondary, picking it up early enough to prevent the effects. And third is to have intervention at least be early enough to have the best outcome. And all these kinds of preventions are the kinds of things that one can do in maternal child health clinics. Now, how to provide this preventive care has many models around the world. Probably the model that is seen the most in the literature, just because so much of the medical literature is written in the United States, is the United States version, where the emphasis is very much on the, just hold on one second, I have a feeling. I'm stopping to share a second because I want to make sure I shared the right version. Yes. Okay, my apologies. Hold on one second. Yeah, is the American version, which is a very, very built system in terms of what is supposed to be done on every single visit. But in this model, all the healthcare is based pretty much on physicians. And given what goes on in the American healthcare system, doesn't necessarily get to everyone in the way that one might desire. Canada bases its form of care similar to the United States. However, it does have a government-funded healthcare system, which means that there is more equity in terms of what is being given. One of the nice things that they added to the world of preventative healthcare is this checklist, that it can be very, very organized even at the time that one is recording the advice, the care that was given. It can be recorded in a systematic fashion. By this point, this not only can be done on paper, this can also be done online, which gives a tremendous amount of data. There are many models around the world. The details of this slide are not what's important. The details is to see how much variety there is between 11 different countries. And in researching this topic, was able to find reports on 20 different countries on which models they provide their preventative healthcare. And in most of the countries, it's a combination of work of physicians and nurses, with the exception of 7 countries in which it is done by physicians primarily. And 1 country in the world which has specially trained nurses, Australia, that provide all this care. But I'm going to focus on Israel's model for doing this. And in the process of this, we're going to talk about the past, present, and future, because Israel's preventative health care clinics are actually older than the state of Israel. If one wants to look at this in further detail, this was published in the Israel Journal of Health Policy Research, the historical development and the current challenges. I will give the very short version. The story actually starts in the late 18th century, when there was very high infant mortality in Europe at that point. Much of this was caused by the Industrial Revolution, where you had mothers who before that had been taking care of their children at home, breastfeeding their children at home, going out to work 12, 14, 18-hour days in such a way that it wasn't possible to take care of their infants, and various forms of milk bottles where animal milks were put in. They were given through these long tubes that you can see here in the picture, led to very poor nutrition, very high infectious disease, and very high infant mortality. There was a physician, originally an army physician, which also shows how trauma can go into preventative health, in France, who felt that the high mortality seemed to be related to the inability to provide clean, pasteurized milk for infants. And he founded a clinic, which he called in French, goutelet, which means a drop of milk. And he was actually able to show within a couple of years that there was a clear difference in infant mortality in his city between those children that were taken care of in this clinic and those that were taken care of and not taken care of in those clinics. This idea of the goutelet spread throughout Europe. It reached also the English-speaking countries, where it was called milk depots. And you see here pictures from New York and from Chicago in the United States. It went over the ocean, ended up in the United States as well. And there was a person by the name of Nathan Strauss, who was living in New York, who pushed this model of milk stations, and he is credited in saving almost 500,000 children. He did this all at his own expense. He made 297 stations in 36 countries around the area. And at the time that the national death rate was 125, it managed to go down to 16. So it had a very major impact. At the same time, in 1909, there was another American who came to see pre-state Israel. And she had social work training. She came and she was completely horrified by the maternal-child conditions that she saw in the country. And she happened to be a friend of Nathan Strauss. She convinced him to come visit the country. He brought 2 American nurses with him, and they founded the first maternal-child health center in 1913. The only problem was that in 1914, World War I broke out. They were foreign nationals and they were kicked out of the country. When the war was over in 1918, that clinic was opened up again. Another one was opened up in 1921, 1922, 1927. And as you see, all of what you have on the right here is a picture of the nurses actually working at these clinics. And on the left, you see a donkey delivering clean pasteurized milk with the words "drop of milk" in 3 different languages, Hebrew, English, and Arabic. Already by 1938, it was very clear that these maternal child clinics were having an impact, because if we look at the infant mortality at this point, we have about 46 per thousand in Australia, 49 per thousand in the United States, and 27 per thousand in Israel, okay? The model continued. Here we see another one of these clinics in one of the kibbutzim in the 1950s. When the state of Israel was founded, the responsibility was taken over by the government. At the beginning, they have some help from UNICEF. On the left here, we have the donation that was given by UNICEF back at that point. At this point, it's no longer funded by UNICEF. And in 1995, Israel's healthcare system had a major change in that they adopted a national health law where all medical care is provided free of charge. Now, this was designed as a little bit of a stepwise system where the first thing was curative care. And then over time, preventative care and mental health were supposed to be given to 4 different health funds as well. However, there was a lot of objections of taking this away from the government. It's been through at least 8 different committees to discuss this. And there was a pilot to try to give it to the health funds. And where we are today is we now have a number of different providers. About 70%, about 60% of the children go to clinics that are funded by the national government. An additional 5 to 10% go to clinics that are funded by 2 cities, one of which is Jerusalem and the other is Tel Aviv. And the reason that they provide the service is because they were providing it before there was a state of Israel, and they just continue to do so. And about 30% of the children are getting their maternal child clinics are in fact provided by their health fund. What's important though is every single one of these clinics is working according to the same national protocols. And that I think is definitely an important part in terms, important point in terms of assuring quality of care. The types of things in the present that are done as, first of all, this is the place where Israel gives its routine childhood immunizations. As a result of this widespread universal free coverage, and I stress the fact that all of these immunizations are free, the overall coverage rate of childhood immunizations is approximately 95%. In these same clinics, the emphasis is to be able to pick up any difficulties in development early, refer the child for further care if necessary. And a lot of counseling goes on. This counseling has to do with breastfeeding and other forms of nutrition. It has to do with safety, which is one of the most important things in terms of preventing child mortality in Israel, and being a place where parents can turn to for advice. A lot of work has been going into bringing, I've so far described the past, I've described the present, what goes on, and a lot of work now is going into trying to describe the future. So one of the issues that has been worked on is the role of the physician in these clinics, because the model from the beginning is that you have both nurses and physicians. Most of the care is provided by the nurses, but there are 5 visits over the course of the 6 years that the children are being taken care of in these clinics, visits from birth to age 6, where the physicians are there. And about 10 years ago, it wasn't exactly clear what the role of the physician is. This study was done looking at different perceptions of what the role of the physician was perceived to be. And as a result of it, there is now a better description and a guide about what the role of the physician is, with a real emphasis on teamwork. Because there's really no reason for the physician to do a developmental screening and the nurse to do a developmental screening. Rather, it makes more sense that if the nurse is doing the developmental screening according to a clear protocol, then the physician can be looking at other items, putting that together with any medical issues the child may have. The physicians are the ones that are doing the physical exams. One of the things, and the fact there are approximately 1,000 of these clinics throughout the country, which provides a very important platform for being able to introduce important preventative programs within the country. So one of the very new processes that has been happening over the last 2 years is improving what is going on in terms of eye health, okay? Because much of visual difficulty, much of even blindness can be prevented if it is picked up early enough. There are a number of things that if they happen in young children and they are not picked up early enough, the brain will not develop in the way that it's supposed to, and then even if it gets fixed later, the child will be cortically blind. So the idea is to be able to pick up these risk factors at an early age. The best way to do it is a combination of tests, each one done at a different area. This is the schedule recommended by the American Academy of Pediatrics. Before 2020, basically what happened in Israel is that the child would have one test called a red reflex done at birth. He would have his vision screened at age 3 and age 5 in our maternal child clinics, using a tool that had never actually been completely validated, and had a vision checked again in 1st grade, and then again in 8th grade. But 1st grade is a very late time to pick up these problems, because if we're trying to pick up the risk factors, they need to be picked up before the age of 6, 7, and therefore it was important to put things in much earlier. So one of the simple tests that one can pick up any of these risk factors is called the red reflex. It's basically shining a light into the child's eyes and seeing if the reflex you get back looks like this, equal and red on both sides. If that is in fact happening, then we know that the light can go through the cornea, go through the lens, go through the liquid of the eye, get to the back of the eye to the nerve, and come back out again. So in one simple test, you're testing a lot of different things. This red reflex is now by protocol done at every physician visit up to 18 months of age. So we've added 3 different times that this is being checked. The physician is also checking to see if the child is cross-eyed in any way by doing another thing called the corneal light reflex, also a very short test. And the children are now being screened at age 4 using a validated vision screening device. Another example of what can be done with having a national preventative service, particularly if you have it computerized. And approximately 10 years ago, the computerization process started in the clinics that are run by the national government, the municipal governments, and one of the health funds. They all use the same computer program. So about 70% of the children are all in one database. And the Ministry of Health has a big data department, which is able to do research on this kind of large data. And as a combined effort of the University of Ben Gurion, the Child Development Center in Beersheba of the Ministry of Health, and some outside consults, we were able to take all the developmental milestones from 2014 to 2020, which is a total of almost 800,000 visits and over 4 million visits, 4 million developmental tests, and actually test the milestones that we were being used. One was able to put out a graph of when it is that children are expected to do this. This will be found in the medical literature, except what we found testing here in Israel is that what is found in the literature does not reflect the reality here in Israel. And therefore, this began a process of rewriting our guidelines such that the time we expect a child to pass the mile line is now based on evidence. So if one's thinking in terms of designing preventative cares, one of the things that I would definitely recommend is to have a database, have the data go in computerized into a database in a way that one can take out the data, because one can then find important local information. Okay, what is, as you've probably guessed by my accent, I'm not originally from Israel, I'm from the United States, and I've worked now in 2 different countries and 2 different health systems, and there are differences between them, which is part of what makes getting local data so important in planning healthcare. Okay, even clinical healthcare. Okay, and as a result of this project, on the left, you see the classic Denver developmental milestones, which is used very often in clinical practice. And on the right, the new milestones that we're planning. The red, green, and yellow is based on how many kids passed it by that time. In other words, by the age. Across the top is the age of the child in months. And by the time one hits red, 95% of the children actually can do it. The stars show where our current milestones are. And you can see that for a number of steps on this, there is a gap between when 95% of children can do it and when we were referring them in the past. And therefore things are, the guidelines are being rewritten so that the times that children will be referred will in fact be based on local evidence and not just what appears in the literature. This past 2 years has, a year and a half, however long this pandemic has been going on, has also led to a lot of thought about providing care at a distance, providing virtual care. Our clinics were open throughout the entire pandemic. However, especially in the first wave, many parents were afraid to go out to bring their child in for care. And as a result of that, a lot of thought has been put into, okay, what services can be provided at a distance? What kind of counseling can be done in a group manner over the internet, over Zoom, over other platforms? And that's definitely something, it has its advantages and its disadvantages. I mean, we feel very strongly that preventative care and the relationship that develops between the staff of the maternal child clinics and the parents is not something that I would want to give over to a computer. But there are times that the computer or other platforms can be useful in terms of getting care at larger distances, which I can certainly imagine could be something useful in terms of spreading, care within the country. Another thing, though, that I will mention is that I keep saying these are maternal child health clinics because historically that was their purpose. Until approximately 10, 15 years ago, no, I guess it's about 20 years at this point, women's prenatal care was given through these clinics as well. Because of the development of technology, such as ultrasounds, which exists in hospitals or clinics and does not exist in these clinics, the majority of women have voted with their feet and no longer come to the clinics for prenatal care. And one of the things that we are trying to do is fill in that gap. If they're not going to get the preventative care here, to make sure that they're getting it someplace else. I think that's another point that could be taken into consideration in terms of when one is using technology, how one distributes that technology, and making sure that there isn't a gap between the technology, the high-tech machines and the low-tech human education, which has been shown to be so important in everything having to do with prevention. So basically up to here, we had an overview of 100 years, pretty much exactly from 1921, when the first one reopened after World War I, of preventative healthcare clinics in Israel, taking an older model and bringing it up to date. And I'd be happy to answer any questions that you might have.
Thank you so much, Dina. It was fascinating. Edwin, would you like to jump over? Any questions?
Yes, we would be happy to take any questions if you have any.
I'm aware that in many countries, this type of care is often done by health visitors or the equivalent, which has the advantage of being able to do the instructions, peer support, local level, etc. That has a lot of advantages, but I think if we're thinking ahead, maybe a combination of existing models together with computerization, digitalization, data, so the care that is being given can be data driven. I think it's very important to realize that just because something's always been done that way for years, it should be looked at again. And it should be looked at again in terms of what the modern needs of families are. One of the things we're trying to develop is to have an application that parents can get access to some of this data at the times that they want, not only times that the clinics are open. We have an after hours call center that parents from around the country can call into. So even if people feel that there's kind of a good existing model for some of the low-tech stuff, I would give some thought into, okay, how can we make this a more consistent, a more data-driven service? Because I think that has a lot of advantages.
Doc, thank you so much. Data has been a big issue in Ghana and how to coordinate and manage it. So I think your submissions would kind of make us think in a particular direction as we try to design and develop these health centers. We appreciate it. Thank you very much.
You're very welcome.
Thank you so much for joining us today. We'll continue to the next session, which will be the session of the solution part. I would like to present Ariel Horowitz from Elad Health. The floor is yours.
Thank you very much. And thanks for the opportunity to present to you Elad Health and our EMR, Chameleon. Tell me if you can see my screen now. Just share it from my side.
Yes, we can, but you can make it full screen if you would like.
Yeah, sure. Okay, so Elad Health was established in 2004. And we are actually the #1 provider for EMR system in Israel. We're doing electronic medical record, and we deployed our system in 45 hospitals up to now, actually holding around 80% market share with currently close to 50,000 active caregivers using the Chameleon. Sorry for this. First of all, what we are doing, what the Chameleon do. We actually do 3 things. One, we documented the patient clinical journey from admin to discharge. Second, we enable the patient 360 view in the hospital, of course, point of care for the caregivers. And I know this is a significant issue, we're collecting a vital clinical sign from other systems or other medical devices across the hospital and put it in the clinical data in the patient file. By the way, if there's any questions during the presentation, please raise it and I will be happy to address. A little bit about our experience in Israel. So actually, we deployed our system in small size, mid-size, and big size hospital. So you can see in this list, it's a partial list, it's not, of course, include all the hospitals that we implemented and deployed our system in Schneider Hospital, for example, in the middle of the chart, hospital that contained 220 beds. In large hospitals such as Sheba Medical Center. Sheba, by the way, is one of the biggest hospitals in the Middle East and contain around or even more than 2,000 beds already. And also in a network, in hospital networks, Clalit HMO, that contains 14 different hospitals. I will touch this in a second. A glimpse of one of the case studies that I wanted to share with you is Clalit Health Management Organization. You can see on the right screen, it's a map of Israel, and the bubbles reflected the hospital locations. So you can see that it's spread all around Israel, from north to south. There is 8 general hospitals belong to this health insurance organization, children ones, and so forth. And actually, if a patient, for example, traveling from north to south and had a car accident and need to hospitalized in the south of Israel, then in a click of the button, the physician over there can see his medical record. You can see his allergies, you can see his X-ray images, you can see a treatment that he had in the past, and so forth. And I assume you understand the importance of this kind of information at this point. So this health organization did since 2012 6.5 million records and contains 24,000 active users and is accredited by the GCIs. do not afraid. It's just one slide show the interoperability capabilities that we have in the system, just to show you with which systems we can collaborate it and share information. And I assume it's important also to you to understand it and to give you some from our end. So first layer is the national system, and here it's depend on the regulations and maybe some other roadmap that you have in your states. And here, as we did in Israel, we can share information to the Ministry of Health, for example, or to other organizations that involved. The next layer is the hospital systems, and here you can find many of these digital components. I just put on the slide a few of them: administration, laboratory, PACS, RIS, ERP, billing, and so forth, and of course the medical equipment. And it's in this point, and it's important you to know that we have many ready-to-go interfaces, so we can that we developed along the way, and we can connect to X-ray, ECGs, pump machines, and many others. So actually, all the information go through digital from the systems, from the medical devices to the Chameleon. We are using international protocols such as DICOM, HS7, BAPI, and others to put in the information. The layer of the end, we are using a very powerful engine called Ensemble to share this information to the Chameleon and to document it, all the information. A glance on the national public response to COVID-19, and this is something unique, I think, that we do here in Israel, and it's important to me to explore this or to give you some information about it from my end. So Hasharon Hospital was the first hospital that implemented or get the so it was initial to hold and treat COVID-19 patients. Hasharon Hospital belonged to Clalit, the organization that I described earlier. And by the way, this health service provider is the biggest one in Israel, and around 4 million insurance belong to him. And as I mentioned, Hasharon was chosen to be a COVID-19 hospital. You can see in this slide the number of beds that the hospital contains and the systems that we attached to the Chameleon. We was chosen by the Ministry of Health to do this operation, this process. And the challenge that we faced with during this session was, first of all, to do it in no time. I mean, to shift the hospital from, I can say, a regular workflow to be under COVID-19, to treat the COVID-19 patients. And we did it in around of a week, okay, just to give you the time slot that we actually do all these activities. That the COVID-19 demands, from one aspect, to remain the clinical processes and communication between the caregivers and the patients, while on the other hand, to minimize the contact between the caregivers or the medical staff and the patient. And this is a huge challenge for any medical staff. And as I mentioned earlier, the Ministry of Health picked the Chameleon to be the system to handle this, or Elad Health to do this job during or based on our leadership in Israel, many years of experience of how to, many years of proven clinical experience and know-how. And so I can say in very short time, we build in interoperability capabilities in this hospital, in Hasharon Hospital. And all these processes, all these documents collecting, management workflow, we made the workflow management ensure we do it. And I can say in the end that we do it, we did it very successfully. And in no time, we managed to continue to share the accurate, efficient, and secure patient data to and from the patient to the caregivers. And was also monitor the patient movements during their hospitalizations of the patients, so the condition that the caregivers can actually monitor the patient movements and their conditions from devices along this way, and continue to do it today. So I'm getting to the end. From my side, just a quick glance of the unique values that Chameleon can bring you. So first of all, we offer the best breed clinical patient management solution. Very powerful customization tool. By the way, this is something that unique us, I think, from other international provider, because we can customize each department, and again, we can be deployed in any clinical departments, or sorry, in any departments or any medical units across the hospital, and we can sit together with your physicians and nurse, and actually took any clinical analog process today and convert it to a digital one. This is what we do. We took paper hospital and convert it to a digital one, and we can do it in each department. Very powerful customization tool, and a very flexible one, and without any needs to approach to the code or to do some things in this area. So this is a big advantage from our side. We can take hospital standing on stage 2 or 0, and according to the HIMSS rewards, if you're familiar with this rank, put them on stage 6 or 7 standards. Because or due to the fact that we developed many interfaces and many gateway between systems and medical devices, we can shorten the time of implementation and save time and money for the hospitals in this process, and in the end bring a very sophisticated and know-how knowledge from our side to you. So thank you very much, and I will be welcome to get any questions whatsoever.
Thank you, Ariel. I think we should move forward because we're already a bit late. And if you have any questions, please make sure you raise it on chat, and Ariel will be following and answering it right away. I would like to invite Ravit from Tyto Care to make a presentation about Tyto.
Hi, everyone. My name is Ravit Kogman. Let me just quickly share my screen. All right, can you guys see my presentation?
Yes.
Okay, perfect. So first of all, thank you for having us. My name is Avi Kogman, and I'm a Director of Business Development for EMEA. And I was very happy to hear the ending while I listened to part of the session provided by Dina, and she really raised the need about bridging the gap, how she mentioned it. Her exact words were to find a solution that would bridge the gap between virtual care and data. And this is really where Tyto comes in to fulfill the promise of telehealth and to really bridge that gap, allowing both patients, caregivers at different points of care at home to have qualitative and quantitative data transported to the clinicians, the physicians, providing them with everything they need to provide a proper diagnosis. So this is Tyto. I don't know if you can see a little bit. Can you see me as well? This is the Tyto kit, okay, with all the adapters, as you can see here on the screen. The Tyto device, it does have an LCD screen with a symptom checker that we will go around with 4 different adapters. We have a tongue depressor, an otoscope, a high fidelity stethoscope, and of course, IR thermometer, and a camera which allows us to do eye examinations, skin examinations, and so on. The accuracy of the exam, of course, as I said, or maybe I need to mention here now, is Tyto is a medical device per se. Okay, we do have CE and FDA approvals, and all of the data captured are of high quality for medical use. And to really complete the solution and to bridge that gap, we do have a trusted provider on the other side, which is the hospital, the caregiver, which completes the puzzle and really fulfilling the true promise of telehealth to be able to provide proper diagnosis, prescriptions, and so on, and have, base your medical decision on actual fact and data. Any consumer can perform the exam. Our app is very intuitive. It will go through the flow, and I'll show you a short video and demo. Of course, we have invested a lot in AI-driven navigation and guidance. The device itself, the Tyto device and the solution would only let you submit an exam after it's been properly identified by the algorithm, making sure that if you're providing an ear exam with the otoscope, that the eardrum is properly captured. And so same goes for the throat. As I'm limited in time and I want to be vigilant on time here, I will show you that in the video, so it will be maybe a clearer way to look at what the physician is able to see. The full stack telehealth platform provided by Tyto has a consumer or a point of care on one side with the Tyto device and app. Of course, our platform, which has a flexible API, allowing full integration with any EHR platforms. Of course, we are HIPAA, GDPR compliant, and we do have a web-based app, which is our Tyto Clinician app. So basically, all the clinician need in order to even control the device for remote is just a web-based app, just a computer or a tablet, and they're able to perform, record, diagnose, take notes all through within the Tyto solution. A bit about the integrations, I won't go into it, but of course, if you have any questions, please feel free, whether at the end by chat or just interrupt me if you like. We provide different types and levels of integration. Apart from the full stack solution provided by Tyto, we have an embedded integration, deep link integration, as you can see here, the iframe in some of our partners, American Well, Epic, and so on. What do we treat? We treat most common primary care with the adapters that I've shown to you before. And of course, this basically replaces the need for an actual physical visit. Anything or any type of exam a physician would perform at his physical clinic can be performed by TytoCare and can either be streamed online or offline in an asynchronous mode to the doctor. We do have 2 types of product offering. One is Tyto Home for families with kids, elderly populations, chronic patients, home monitoring for chronic patients, infectious disease and COVID. I'll show you a short video of what we did with Sheba. And of course, Tyto Pro. Tyto Pro is for professional care. It doesn't have to be necessarily a medical side or a nurse on the other side, but somebody who is trained to perform the Tyto exam and then record them through the app, transmit them to the doctor, or assist in performing an online visit. A few of the use cases we have today are the traveling nurses, of course, the hospitals, home care, elderly homes, remote clinics, retail pharmacies, for example, with Care in France, which is to be owned by AXA. I'm sure you all know. We do have in rural areas a Tyto station in a separate room in which caregiver performs the exam, allowing the physician to write a prescription based on the data collected and get the full service basically at the pharmacy or community center, school clinics, work sites, ambulatory care, Israel MDA, MADA services using Tyto to decide whether evacuation needs to be done or the patient can be treated on the spot. A little bit about Tyto. We have over 300,000 patients on our platform. Only in 2020, we provided over 600,000 exams with an NPS score of over 76. Tyto has been on the market effectively treating patients and supporting clinicians for over 4 years. We started with the FDA and therefore widely spread in the US, and moving on upon receiving CE approval to many other countries, which I will show you just a bit of the locations in a little while. And regarding the satisfaction and survey record, we do see that over 96% of the visits performed by Tyto Care virtual consultations. Data is taken, by the way, from, I see that as mentioned earlier, Israel's HMO Clalit, which is one of our customers, and they have indicated that over 96% of the actual visits were resolved by the consultation done by Tyto Care. So we have over 8,000 providers on platform, and we cooperate with over 160 health organizations available in over 18 countries. Go-to-market traction, just a little bit about the strategic partners such as American Well, Epic, Cleveland Clinic, Anthem, of course, Clalit, Suica, which is one of the largest insurers in Switzerland, Clalit, which is the largest HMO in Israel. We also work with Meuchedet and Leumit, which are the other HMOs in the Israeli market. A little bit about our track around the globe. As I said, we started in the US, but today we are active in London in the UK in general with the NHS. We have a large operation set up in South Africa through Discovery Service. Discovery is an insurance company, the largest, I believe, in South Africa. Of course, Care, Suica, Clalit is mentioned, and also in the Far East. I want to run you through a quick product demonstration just to show you what Tyto would look like when performing an exam. As I mentioned, we do have the offline exams. There are actually two exam modes. One is the offline exam, an asynchronous exam, in which the patient or a caregiver or a nurse can perform the exams and then send them over to the doctor. The doctor will then review performance diagnosis, and then in case of need, will initiate a visit through the Tyto app. The other option is an online exam in which we stream live data. The clinician has full control over the device. The device is being locked and he's guiding the patient on how to conduct the exam. It has the ability, the physician has the ability to record. By the way, this is a part of the features that we do have, is allowing multiple consultations with experts and specialists while looking at the video, performing their consultation, whether they're both in the same hospital or different hospitals, allowing them to really have multiple consultation and provide diagnosis. Pre-exam, offline mode, we do have a symptom checker in which the patient can check the symptoms, the moderation of the pain, how long he's been experiencing such a symptom, and the device will basically suggest the exams to be performed. Of course, there could be additional exams added, or not all exams can be performed. And of course, for every exam performed by the Tyto device, there is an exam guidance, not only by tutorial, but also, as I mentioned earlier, with the AI guidance, making sure the image is captured properly in, when we're talking about auscultation sound, we do have a noise indicator index to make sure that the room is quiet. The patient or the caregiver will also receive a remark if, let's say, they're pressing too hard on the stethoscope, not providing good auscultation, or not capturing the proper eardrum. Here you see an example, you will see it also in the video shortly, of what an AI capture and symptom and checker would look like on the device. Only after the desired image is captured, the patient will be, or the caregiver will be able to submit the exam to the doctor. You can see here with the heart exam, there is also not just the imaging as we've seen in other exams, but also the location where patients should place it on the body, and we really guide you through the process, making sure we bridge that gap truly and provide the doctor with the data needed. Here we'll see a short demo of the ear exam with the guidance of the TytoCare. Of course, the mom is performing the ear exam, attaching the otoscope. We have the guidance, but also, as you can see here, once the eardrum is being identified, we will have a green check mark, making sure that the quality of the image is good enough, and then the result can be submitted to the doctor for diagnosis. Throat exam with the tongue depressor. As you can see here, the mother is attaching the tongue depressor, making sure that tongue does not block the image. Once the ovule and the tonsils are being identified, we have that green check mark and we can submit the exam. Lung guidance. You see here the noise indicator. If the room will be noisy, you will see the level of the auscultation sound will not turn green. It will also give you instructions. It shows you where to place the device on the body while performing the exam and then sending over. Once you get the verification, you're able to send it to the doctor. Online exam, just what it would look like from the clinician side. On the right side of the screen, you can see the clinician app. The clinician is able to, of course, look at the images captured online, but also record them and then re-listen to them. We do have the ability to play with the clarity, with the illumination of the image. Auscultation sound can be used on different type of sounds. Of course, we recommend the clinician to use the headphones when using the listening to the auscultation sounds. But the other advantage and huge advantage is not only they can write the notes and remarks, but when doing consultations, monitoring chronic patients or doing consultations within hospitals with different specialists, they do not only rely on the notes that are being taken, but only on the live images captured through the exam. A little bit about hospital usage, and I'll show you shortly a case study we have performed successfully with Sheba, which was mentioned earlier. Sheba is one of the top 10 hospitals in the world for innovation, and we had a very successful activities with the monitoring COVID patients and then doing also follow-up post-op monitoring of patients with joint operation with Maccabi. Follow-up visit of ambulatory care for chronic patients, of course, visiting nurses at home. I mentioned previously the inner hospital consultations, allowing both clinicians to be virtually in the same exam room, even if they're in different locations at the hospital or outside the hospitals or in different hospitals. And there goes for the inter-hospital communication, even, decision support before transferring a patient from the ER, discharging a patient, or even sending a patient home to do home hospitalization under the care of the hospital. But still, if there is a bed shortage or there is no need to keep the patient any longer in the quarantine ward, they can be released to their own home. I want to switch, I mentioned earlier, the Sheba Medical Center and what we have performed with them, how they monitored COVID patients at home. And just, if I may, I will share with you the video. Are you able to see the video? can you see my screen and video? I don't know.
Yes, we can.
Ah, okay.
There is no sound though.
Oh, you don't see? Okay. Let's see what the sound. Just 1 second. Here we see. So I'll try to just 1 sec. Let me try to see what's with the sound. I know sound here seems pretty good. Okay. How's the sound now? Do you have sound now?
Try again.
All right. Do you hear the sound?
I don't think so.
Okay, so I'll just run you through it. There is basically we're using the translation. There is a kit left at the patient doorstep. The patient is a COVID patient who needs to be monitored. She's no longer in critical condition, but can be monitored from home. Here you see she receives a package with a TITO device, a laptop with the ad, and the doctor is initiating the visit. So if you're not hearing this now, just 1 second. Let me take off. Okay, so I can hear myself. All right. Here, the doctor has initiated the visit through the TITO app on the tablet, and he is doing a follow-up process. He's measuring her body temperature, instructing her how to do so. You see, he has the earphones on. The device is locked. If you can see the lock sign on the device itself, he's instructing her to place the thermometer. The reading will appear on the doctor's screen, okay, as a part of the clinician app. Here he's capturing throat images and instructing her to connect the stethoscope and listen to the auscultation sounds. They're also being recorded. All of the exams are initiated through the clinician app. The patient has nothing to do with any, apart from connecting the adapters, there is nothing the patient is actually doing during the exam. Now here you see satisfied with the results. There is no evidence of pneumonia, and the heart rate is normal. No throat infection. The condition is normal. They will continue to monitor the patient, and they are releasing her in 2 days from quarantine. I'll be happy to share the video with you and also discuss further some additional cases we have done. As you see here in Freiburg Hospital in Switzerland, to serve elderly care homes and have a physician monitor them from the hospital in case they face mobility issues, but also not to expose them to unnecessary risk by attending the hospitals. Also, another thing is in quarantine wards within the hospitals, there's no need for the staff to enter and do all of the gearing up required for quarantine wards. They have implemented TITO Pro as part of their surveys. The nurses examine the elderly patients with the TITO. Also, another very nice and interesting, which has a lot of coverage, is our project at the Vercelli Hospital in Italy during COVID for COVID patients. They were monitored in the same way that we've witnessed in Sheba in different facilities that were closed under COVID quarantine. Basically, you know, to allow home monitoring, to monitor chronic patients, to have the traveling nurses if people cannot perform the exams by themselves. This does reduce the load on the hospitals. It reduces the load even if you're handling using TITO as part of your solution within the hospital, and of course by not risking and exposing either the staff or the patients who are coming to the ER or the clinics. We have implemented also the same type of solution in Thai hospitals, in Samiti Veg Hospital, who deployed TITO 48 hospitals also to monitor COVID in quarantine wards, allowing increased accessibilities to physicians even when they faced a situation in which some of the doctors had to be quarantined at home, they were feeling well, but they could not come to the hospital. They were able to support the hospital and reduce the load by performing remote consultation through the TITO. We talked about a little bit, I touched the active health programs we've done with Clalit, the HMO, which has over 4.5 million patients. We have distributed over 20,000 kits for families with over 70,000 patients. We have over 70% utilization. As I mentioned earlier, 93% of the virtual visits are not prolonged by a physical visit. They're resolved. The doctor is allowed. He has enough data to perform a diagnosis. We have Clalit patients, mentioning that they have children up to 5 years old who've never seen a clinic because everything is being solved remotely by TITO. If we're talking about ear infection, asthma, children's asthma, and so on. Most of the patients are transitioning to virtual care, primary care by TITO, especially families with young kids, pregnant women, trying to avoid risk and saving time. Of course, with Anthem, and a little bit maybe to have a different use case performed by Swica. Swica is the insurance company in Switzerland who's also providing healthcare service. They're using TITO as part of the TRIDE service. There is a nurse call center, and by performing the TITO visit, the nurse will decide at the initial point whether a doctor needs to be contacted or the case can be resolved with just a concern, there's no infections and so on, or whether a prescription is needed. So I guess that's it in a nutshell. Of course, I welcome any questions, and there are additional use cases which I'll be happy to share.
Thank you so much, Ravit. Any questions to Ravit by chat, please, because we have to move on. And I would like to invite Anya and Elad from Datos Health.
Actually, Roy, but thank you.
Sorry.
That's fine. So thank you very much for having us today. Let me just share my screen. We can go over Datos Health. 1 second. Can you see my screen?
Yes.
Great. So I'm here today to talk about Datos, which is a remote care automation and remote patient monitoring platform. Datos has been around since 2015. We work across the Israeli healthcare market, work with Clalit, which both TITO and Elad system mentioned earlier. It is the largest HMO here in Israel. We also work with the second largest HMO, which is Maccabi. Both of them have cover patients in the millions. Our biggest partner here in Israel is probably the Sheba Medical Center, which was also mentioned by TITO and Elad system. It is I think it's the 9th largest in the world with over 2,000 beds. It's definitely one of the most technologically advanced hospitals. And also we work with the Ministry of Health, which owns and operates 25 different hospitals. Over in the US, we work with Kaiser Permanente, which is the largest health organization in the US. And also with Amgen, which is a pharmaceutical company, and various different research universities. Our platform basically does a little bit of what Elad system showed there, and a little bit of what TITO is doing, is we can create multiple different care pathways for treating patients while they're at home. So not at a hospital setting, while they're at home. And the way we do that is we give health organizations the ability to create those care pathway without any code, without any knowledge or deep knowledge in IT. It's all in a drag and drop environment, and it allows the health organization to utilize prompts or surveys and also connect to devices. So we are not a device company. we integrate with various different devices. We have integration with over 60 different devices. And they vary from continuous temperature patches, ECG patches, blood pressure devices, glucometers, pulse oximeters, also activity trackers like Garmin, Apple, Fitbit, Polar. We have integration with all these devices. On the clinician side, there's a dashboard to manage those patients at home that basically alerts the clinicians when the patient requires assistance. So it can be either in an asynchronous manner where you log in and you see low risk patients and you see their alerts and you can go through that whenever you have the time to do so. Or it can be real-time monitoring of at-home hospitalized patients. On the patient side, there's an app that allows the patient to conduct video calls with the clinicians, reply to prompts, or basically provide any information that the clinician feels is necessary. So those are the elements. Our platform really allows, like I said, integration with devices, utilization of surveys, prompts, virtual visits through our telemedicine component, automation through, you can set up alerts based on incoming vital information or based on survey information. And you can really automate the processes that you currently have now, whether they're analog or like paper processes. You can now do that digitally and treat patients while they're at home and not in a hospital setting if they don't really require to go to the hospital. So some of the use cases that were created on our platform, but they're not limited to, are around remote cardiac rehabilitation, psychiatry home hospitalization, hypertension, diabetes, virtual clinics for any really cohort. COVID-19, the Ministry of Health actually contracted us to monitor all positive COVID patients when the crisis started last year. Oncology symptom management, which is a program that's running both in the Ministry of Health and Sheba. And it really takes the load off the clinician and also to the patients who are already going through something very, very serious. And if we can reduce their hospitalization days or hospitalization visits, then we already did a great job. IBD symptom management, CHF, and PROMs, like I said, heavily used PROMs or surveys. So this is a snapshot currently of what's going on with the Sheba Medical Center. They started in 2018 with remote cardiac rehab. They're now doing virtual visits or video calls across the entire hospital, psychiatry home hospitalization, breast cancer symptom management. They recently started treating patients in the UAE, in Dubai, using the Datos platform. The clinicians are in Israel and the patients are in Dubai, and they're able to do that with the utilization of glucometers and virtual visits. And just to say the list, there's various other programs that they are running, including Parkinson and LVAD and many others that are not even in the slide. Similar use case, similar type of flow is happening with our customer Kaiser Permanente. We started with symptom management for COVID. They're now doing pulmonary rehab. They're doing a wellness program for their employees on the Datos platform, and that will obviously continue to grow. That's typical. That's the very typical Datos implementation. Starts with one simple use case, and then that grows to additional use cases after the clinicians are more adapted to the platform. So some of the things that were written about us after the crisis has started, we managed to set up environments or systems for various different customers around the world with a COVID monitoring plan. In upstate New York, we work with Monroe County and also Rochester Regional Health. And here in Israel, of course, with Sheba and Ministry of Health and so on. Some of our very happy customers include Mount Sinai, Rochester Regional Health, of course, the Sheba Medical Center, and Amgen, which is it's a pharmaceutical company. And they created their clinical trial protocol on the Datos platform, which allows them to do additional locations and really streamline the information coming from those sites. So happy to set up another call or take questions. Thank you very much.
Thank you so much. Any questions for Roy?
I'm around, so I'll share the presentation.
Thank you so much. So if anybody has any question, Roy is available by chat in the next few minutes. Thank you very much for all of you that have taken the time and joined us for the session today. I just want to emphasize that the last session of this seminar would be next week on Monday instead of Wednesday as it used to be. So make sure you have it on your calendar. It's on Monday, the 23rd of August, same time, 1 p.m. Israel time, 10 a.m. Ghana time. Edwin or Amma, would you like to say some words? Or maybe even...
Yes. Yes, thank you very much, Maria. We appreciate organizing these sessions for us. Today's session has been very informative, and we do appreciate it. We know that there's a lot of noise coming out from the presidency about this project, and we believe whatever we are learning here would equip us and give us the best posture, if I can say it, in trying to deliver a world-class project to the people of Ghana. Mr. Nyako and Amma have been instrumental in making us give the best here, and we would like to thank them. I know that they've been on the road, but they still made it here, and we appreciate it. Mr. Nyako, we appreciate it so much. And we thank you for this opportunity. Thank you everyone for joining. It's been really fun, and we look forward to meeting you next week, Monday. I'm done. Thank you.
Thank you so much. Mr. Nyako, would you like to say a few words? If not, then thank you so much again, and we'll see you Monday next week. Enjoy your day.
Okay. When you see if everything is okay, you sign.
No, he will sign.
No, you have the medical, you sign, then you give to him, he will